So I hear only Christian, but if he shouts perfect, so I'm thinking everything is good. Okay. So dear Professor Mills, dear Professor Nickel, I'm truly sorry, dear friends and colleagues, that I am not able to attend this year in person at the great meeting. But as long as we cardiac surgeons still have some work left and the cardiologists are not standing everything, I'm happy to be on call. And that's the reason why I cannot be in Rome together with you. However, I'm very happy to talk today about the hs-cTnl-Exl, our algorithm criteria for a novel high sensitivity cardiac troponin I assay. These are my disclosures, but the more important disclosure slides are these one here. I'm truly grateful to be a part of the fantastic research team of the Cardiovascular Research Institute in Basel. And I'm very happy to be a part of the great network with great researchers, but of course also great soccer players. As you all know, lately, several novel high sensitivity cardiac troponin assays have been developed. And before their introduction into daily clinical routine, it's mandatory that these assays are validated in large clinical trials. Furthermore, the hs-cTnl-Exl, our algorithm, is assay specific, meaning we have to derive and validate new cutoff criteria whenever a new assay is introduced. Therefore, the aim of this project was to assess the diagnostic accuracy of the high sensitivity cardiac troponin I-Exl assay, and in a second part to derive and validate an assay-specific 0-1-hour algorithm. To address these questions, we use data from our large international APACE trial, where patients are included when they presented to the emergency department with symptoms suggestive of acute MI. Final diagnoses were adjudicated by 2 independent cardiologists applying the 4th universal definition of myocardial infarction, using all available medical records up to a 3-month follow-up, including serial measurements of high sensitivity cardiac troponin. For this analysis, since we aimed to validate a troponin I assay, we used serial measurements of high sensitivity cardiac troponin I architect for central adjudication for the primary analysis, and performed a secondary analysis using serial measurements of high sensitivity cardiac troponin T for central adjudication. A few words about the assay. The high sensitivity cardiac troponin I-Exl assay has a limit of blank of 1.1 and the limit of detection of 2.7 nanograms per liter, and the combined 99th percentile of 60.4 nanograms per liter, slightly higher for male and lower for female. In our study, we included 1,454 patients representing a typical chest pain cohort with a median age of about 60 years, a quite high amount of early presenters, meaning presentation within 3 hours after chest pain onset in about 40% of the patients, and a prevalence of non-ST elevation myocardial infarction, about 14% of the patients. Now here you can see the concentrations of the troponin I at presentation according to the final diagnosis: acute myocardial infarction, unstable angina, cardiac not coronary chest pain such as heart failure or rhythm disorders, non-cardiac chest pain such as musculoskeletal pain, and unknown pain. As expected, the median troponin concentrations were significantly higher in patients with an adjudicated myocardial infarction compared to patients without an acute myocardial infarction. Now, the diagnostic accuracy of the troponin I-Exl assay was very high, with an area under the curve of 0.94, and a comparable performance compared to troponin I-Architect, and even statistically superior to troponin T-Alexis when using serial measurements of troponin I for central adjudication. Also, in the vulnerable subgroup of early presenters, the diagnostic accuracy was very high, with an area under the curve of 0.93, and again, a comparable performance to troponin I-Architect and troponin T-Alexis. Now, as said before, these findings were confirmed in a sensitivity analysis using serial measurements of high sensitivity cardiac troponin T instead of I for central adjudication. And again, in all patients, as well as in early presenters, the diagnostic accuracy of the troponin I-Exl assay was very high and comparable to troponin I-Architect and troponin T-Alexis. So for the second part of this project and the derivation and validation of the troponin I-0-1-hour algorithm, we of course had to exclude all patients where we did not have a 1-hour level of the troponin I-Exl. To be consistent with previous published papers, we randomly split our data set to a derivation group and a validation group in a relation of 70 to 30. As before, we aimed for a predefined negative predictive value over 99% for rule out, and a predefined positive predictive value over 70% for rule in. Applying the here presented cutoff criteria, we were able to rule out about 60% of the cohort with a very high negative predictive value and a very high sensitivity, and no missed patient with acute myocardial infarction. We could rule in about 10% of the patients with a high positive predictive value and a high specificity. 1/3 of the patients remained in the observed zone, meaning they could not be triaged into rule in or rule out after 1 hour. Similar findings were seen in the validation cohort. Again, about 60% of the patients could be ruled out, about 10% of the patients could be ruled in, and about 1/3 of the patients remained in the observed zone. However, in the validation cohort, 1 patient with an adjudicated myocardial infarction was missed, leading to a negative predictive value of 99.5%. This 1 patient was a patient with a type 1 myocardial infarction. It was an early present with chest pain onset before 2 hours, meaning we missed him here in the second part of the rule out component, and we missed him because of a low delta of 4, which was below the cutoff of 5. Last but not least, I want to show you the overall survival according to the 3 groups: rule out, observed, and rule in. And what we can see is a very high 30-day survival of 99.8% and a very high 730-day survival of 97.1% in the rule out group, showing the safety of the rule out approach and lower survival rates in the observed zone and in the rule in group. Now, what are the limitations? We need further studies to quantify the utility of the rule out and rule in strategies in patients with a higher or lower pre-test probability, meaning in another setting than the emergency department. Further studies applying these diagnostic algorithms prospectively for clinical decision-making are needed. And as general for the APACE trial, we cannot generalize our findings to patients with terminal kidney failure requiring dialysis, since these patients are excluded. However, I want to summarize that the diagnostic accuracy of the high sensitivity cardiac troponin I-Exl assay was very high and comparable to the both most widely validated assays, troponin I-Architect and troponin T-Alexis. These findings were consistent in the group of early presenters and when using serial measurements of high sensitivity cardiac troponin T instead of I for central adjudication. The derived and validated algorithm showed a high safety and accuracy for rule out and rule in. However, 1/3 of the patients remained in the observed zone, which is slightly higher compared to other assays. And with this slide, I want to conclude and thank you very much for your attention.
Thanks, Luca. Can you hear me okay?
Perfectly.
Yeah, lovely presentation. Delighted for the patients and for the Italian great football team that you are not able to be with us. But we enjoyed your presentation. The question I wanted to ask you really was about the gold standard. I thought it was really interesting that you applied 2 different approaches there. Just talk me through your thinking.
Absolutely. So as you said correctly, we have there are 2 ways for the gold standard diagnosis of the central adjudication, meaning for one, we used additionally to all available medical records up to a 3-month follow-up and including study-specific records such as specifically chest pain characteristics, we use serial measurements of high sensitivity cardiac troponin T. However, when using troponin T assay for the central adjudication, this may introduce a bias in favor to troponin T when comparing a troponin T assay and a troponin I assay. Therefore, as a second part, or in a different way of the gold standard, or a different way of the central adjudication, we used serial measurements of the troponin I-Architect assay instead of the troponin T-Alexis assay, so that the gold standard diagnosis is based, besides all medical information, on serial measurements of high sensitivity cardiac troponin I rather than T. We think this is a very important additional quality when using the central adjudication and when comparing different assays.
That's a good answer. It's a really difficult thing to do, isn't it? I mean, particularly when you have a pathway which addresses both rule in and rule out. I guess in practice, when this is applied, the same assay will be used on peak measurements as will be used at the initial triage. Did you consider using peak measurements of the new Siemens assay as your gold standard?
peak assays in what time period? We have, like for the early rule out and rule in, for the early diagnose, for the early algorithm, we of course needed the troponin concentrations at presentation, and for the scheme of the 1 hour algorithm, of course, the values at 0 hour, so at presentation and at 1 hour. We also have, like in the study-specific assessments and blood samples, we have the peak values up to 6 hours where we could analyze if we would want to. I don't know if I did understand your question correctly.
Additional reassurance for the early rule out of patients to know that the late samples measured with the Siemens assay were also reassuringly normal or below your diagnostic threshold. But it's perhaps it's a minor technical point. Fabulous to finally come up with a biomarker, having seen glucose and neutrophil lymphocyte ratios fail, that is as good as our previous markers. So